You're live.
Did we start?
Yes, we are set.
Good evening, everyone, and welcome to another series of International Dermatology Education Foundation educational programs. Tonight, we are very lucky to have Dr. Hilary Baldwin from Rutgers Rubberwood Johnson Medical Center. And we're gonna discuss the role of natural moisturizing factors in skin moisturization, going beyond ceramides. However, before we go on our program, we have a couple of housekeeping items. First, we'd like to thank our supporter, Beiersdorf, makers of Eucerin and Aquaphor, for supporting and for tonight's program. Before we begin, if you're having issues hearing the webinar, you can listen to the presentation using your telephone. Just select phone call in the audio pane and the dial information will be displayed. At the end of this webinar, a survey will pop up in your browser and will be mailed to you within 1 to 2 days. We would greatly appreciate if you could fill out this short survey. If you're having technical issues, please submit your question in the questions pane on the right-hand side of your screen. Within 1 to 2 days of the webinar, a certificate of attendance will be emailed to you. So before we go any further, I want to tell you a little bit about our foundation. International Dermatology Education Foundation, a non-profit organization whose principal mission is to raise awareness and improve dermatology care all over the world through education, especially in underserved areas. As you know, we have been in both North America, US, Canada, as well as South America, Europe, Southeast Asia, with many different programs in medical dermatology, as well as all skin products. So tonight, we are very lucky to have a good friend of mine from Brooklyn, Dr. Hilary Baldwin, and she's going to tell us all about going beyond ceramides, the role of natural moisturizing factors in skin moisturization. Welcome. Good to see you, Hilary. Please take it over.
Thank you so much. It's such a pleasure to be here today. And as Leon said, we're going to be talking about the role of natural moisturizing factors in skin moisturization, a topic that I knew very, very little about coming out of my residency. I'm not sure. Of course, that was back when we were practicing paleodermatology in the 80s. I hope that that residents these days know more than we did at the time. But still, it's always worthwhile to review this difficult topic. So, oops, sorry, a little sensitive. So this is the agenda for tonight. We're going to talk a little bit about Beiersdorf, a little company overview, and then we're going to go on to talk about the science of the epidermal barrier, the structure and function of the barrier. Looking at the evolution of moisturizers over the years from basic barrier protection, which was back in the early 80s, mostly petrolatum, for example, all the way to today where we have lovely therapeutic moisturizers that have specific reasons for being used for specific conditions. We're going to look primarily tonight, though, at xerosis. We're going to do a little bit of the disease overview, and then we're going to talk about two products that can be used to treat xerotic skin, namely Eucerin Advanced Repair Cream and Lotion, and we're going to look at head-to-head clinical efficacy data for both of those products. So without further ado, let's start by going over a little bit of the company history of Beiersdorf. It's a very old company. It was founded in Hamburg back in 1882. And we can see on the right all of the icons of very familiar brands here in the US and some brands that are global that we don't have around here. But I remember Coppertone when I was a very young child. So I think that when we talk about over-the-counter products, sometimes it's our impression that the science behind them is not quite as rigorous as it is for the prescription products, but we would be quite wrong. There's a lot of science behind this, a lot of studies, and we're going to see several of them tonight. Over 1,750 studies on more than 44,000 international participants, all as a part of their commitment to innovation. And speaking about innovation, brand new, 32,000 square foot state-of-the-art innovation center now in Florham Park, New Jersey. That includes a consumer sensory panel focus room, a good medical practice laboratory, and more than 60 scientists who are focused exclusively on finding novel ingredients and formulations to help our patients improve their skin health. So without further ado, let's go on and look at the epidermal barrier and the science behind it. I'd like to offer you, by the way, before we get started, go ahead and put any kind of questions into the Q&A as things are going along. It's always easier to be asking the questions when they dawn on you rather than waiting until the end. So let's start with the barrier function of the skin. And we sort of artificially separate this into microbial, physical, chemical, immunologic, and neurosensory barriers. Of course, those activities are seen pretty much throughout the epidermis, and they're not quite distinctly separated like this, but for the sake of simplicity, it's easier to look at it this way. I'd like to point out that probably 10 years ago or so, we wouldn't have had microbial barrier there at the top. Maybe some of the photographs showed a couple of little bacteria hanging out on the surface of the skin, implying that, yeah, there's bacteria on the outside of the skin, no big shock. But now we recognize that the microbiome of the skin is crucial to the health of the barrier function of the skin. They have a mutualistic relationship where the skin provides a place for the bacteria to live, and water and food and a niche for it to hang out in, and the bacteria provide homeostasis. They take up the niche and eat the nutrients that otherwise might be taken up by and eaten by more pathogenic organisms. The bacteria also keep the pH of the skin nice and low, which means that the enzymes in the stratum corneum can function up to full capacity. So it's a very mutualistic relationship. Below that, we have the physical barrier, with which we're all very familiar, mostly the stratum corneum, which consists of corneocytes, which are held together by desmosomes, and further held together by the tight junctions where the claudins come into play, and also separated the cells separated by this lipid barrier, the lipid matrix between them, sort of like brick and mortar, as we'll see in a moment. And then we have the chemical barrier, which is largely what we're going to be talking about tonight, which consists of the hydration molecules, which include natural moisturizing factors, as well as containing the antimicrobial peptides, which are a crucial part of the innate immune process. So an extremely complicated and very demanding barrier function of the skin. So as I said before, we can look at the stratum corneum very simplistically, obviously, as a brick and mortar model where the corneocytes, they're now called corneocytes because they've lost their nucleus, so they've turned from keratinocytes into corneocytes, are separated by the lipid matrix. We have cornea desmosomes that are holding the corneocytes together until it reaches the top, where they are degraded so that the top layer can slough off into the environment. The lipid matrix keeping the holes between the corneocytes filled up so that this is clearly a physical barrier to the outside world, stopping bacteria and pollutants and allergens from coming in, and also stopping water from evaporating from the skin. The cornea desmosomes, as I said before, are holding those corneocytes together. And the cornea desmosomes have several components to them, as you can see over on the right, desmogliin and desmocollin and cornea desmosine, which are all crucial. They're cadherin molecules that help that make up the cornea desmosomes. And these provide this tight junction, which increases the tensile strength of the stratum corneum and resists shearing forces, so allows the skin to bend and to move and to rub against outside material without breaking down. And then in the chemical level, as we said before, the essential role, we have the endogenous natural moisturizing factors. I remember when I first heard this name, I thought, well, gosh, that's something that they made up on Madison Avenue, but that's the real name for these natural factors within the skin, which are hygroscopic molecules that attract and hold and retain water and help to maintain the hydration of the epidermis. And we need the epidermis to be hydrated in order for the enzymes to work appropriately. They are a very large part of the stratum granulosum, representing 20 to 30% of the dry weight of the stratum corneum. And you can see in the pie chart over on the right what components make up the endogenous natural moisturizing factors, which includes urea, as well as amino acids, inorganic salts, lactate, pyrrolidone, carboxylic acid, and other agents. Decrease in the natural moisturizing factor, whether it's from disease like xerosis or atopic dermatitis, or due to a genetic mutation, results in dehydration of the epidermis and dryness and roughness and pruritus and other skin diseases. And we can actually measure the amount of hydration in the skin, which is a poor man's way of calculating if there's enough natural moisturizing factors, by using corneometry, which measures the hydration. So we have, again, the natural moisturizing factors coming from the breakdown of the filaggrin, which is found within the corneocytes in the stratum granulosum. So here we see this again, the healthy skin barrier. Over on the left, we're looking at profilaggrin, which is a structural component of the cornified envelope itself, which is processed into filaggrin, and filaggrin breaks down or degrades into the natural moisturizing factors within the corneocytes. And they attract water and hold on to water, so you have a swelled, moisture-laden corneocyte. And then in the middle, we can see the story of the corneodesmosomes. We said that they are holding the corneocytes together, and that helps them to have the tensile strength of the skin, but they do have to desquamate eventually in order for the cells to shed out into the world so that new cells from the basal layer can come up and replenish them. And the rate of desquamation is determined by protease inhibitors and the proteases that degrade the corneocytes, the corneodesmosomes. So it's a very delicate balance between inhibition of these proteases and activity of these proteases. Now, the skin surface pH is low, usually 5.5 or so, but actually the proteases prefer a slightly more alkaline environment, and we're going to get to why that's important in a moment. So a little bit further down, it's a little bit alkaline, which is where the proteases are doing their thing. And on the skin surface, we're looking at a nice low pH of 5.5 or so in order to maximize the functioning of the stratum corneum and the lipid lamellae. So here we see that the lipid lamellae are encasing corneocytes, preventing water loss, reducing barrier permeability, and we want it only degraded in the very upper layers of the stratum corneum because it needs to be functioning and intact to reduce the infiltration of allergens and pollutants, as well as to stop transepidermal water loss. And decreased synthesis of the lipid lamellae is associated with a breakdown of the epidermal barrier. So let's talk for a moment about the pH of the skin and the importance of that acidic pH on the surface of the skin. It's vital for maintaining normal barrier function, because without it, the serum proteases are not functioning up to snuff, and we end up with too much desquamation or too little desquamation, with thickening of the skin, or with a early desquamation resulting in irritated skin and a decrease in barrier function. Regulation of the lipid lamellae is also crucially important, and that is accomplished by the enzymes that are in the upper levels of the stratum corneum, and they behave their best at an acidic pH. And we said before that the proteases sometimes like a slightly higher pH, and that's what we have in atopic dermatitis, isn't it? Patients with atopic dermatitis have a higher pH of their skin, so those proteases are working overtime, so you get more desquamation of the surface of the skin, breakdown in the barrier, resulting in atopic dermatitis or worsening of atopic dermatitis in a very circular fashion. So this increase in the pH leads to a compromised barrier. So we want to make sure that any kind of cleanser we use or any type of moisturizer we use has a nice low pH to maintain the pH of the surface of the skin in its healthiest fashion. So moving on now to the solution to this problem. The solution to this problem are moisturizers, to add natural moisturizing factors, to add lipids, to help skin which is deficient in either one of those agents. Now, back again when I was a resident, what we really had was not a whole lot more than petrolatum with some, sometimes with some water whipped into it. We didn't have all of the bells and whistles that we have now. Occlusives, though, are still very important. It's important to have the occlusive to seal in moisture, right? So without that, and without a normal barrier, we are evaporating out into the air. So we want a nice occlusive there to protect the skin and to reduce transepidermal water loss. But if you put something that's just an occlusive on top of bone dry skin, you basically have greasy bone dry skin. So you want to moisturize at the same time. And that's where humectants come in. So humectants bring in and trap and maintain the moisture, and then the occlusive can seal that moisture in. So the combination of the two make for a very high quality moisturizer. And then when we're talking about therapeutic rationale, do we want to add ceramides? Do we want to add niacinamide? Do we want to add natural moisturizing factors to replenish what may be deficient in a particular skin condition? And that's where the therapeutic moisturizers come into play, which have come into common use only in the last 10 years or so. So obviously, not all moisturizers are created equal. And we see on the left the moisturizer type, the occlusive, which is primarily ointments and very rich creams and lotions. And its job is to be a protectant and to prevent transepidermal water loss and to shield from outside irritants. The humectants are going to hydrate, and they're fast-absorbing creams and lotions that contain humectants like glycerin or other components of natural moisturizing factor that we saw in that pie before. And then with the therapeutic moisturizers, we're adding things that might, again, skin protectant, of course, and barrier lipids, anti-itch, antioxidant, anti-inflammatory, to protect, hydrate, and also to fix specific deficiencies in the specific disease for which the moisturizer has been intended. So the condition that we're talking about tonight is xerosis. So let's do a little disease overview of xerosis, recognizing that it is incredibly common worldwide, with a prevalence estimated at 29 to 85%. Obviously, that's a very big gap, but it depends on where you are and what kind of patients you're looking at, because an increased incidence of xerosis is associated with age, increasing age, being female, the body mass index, of course, outside temperature and climate. In a very humid atmosphere, there's not as much xerosis. Very dry, very hot, or very cold climates might be a harbinger of more xerosis. Patients, of course, with any kind of eczema, and patients undergoing chemotherapy, just to mention a few. We know that xerosis is caused either by endogenous factors or exogenous factors, or sometimes a combination of the two. Endogenous factors, many of these, are genetic mutations. So patients who are born with ceramide deficiency or have a ceramide deficiency as a result of their disease, filaggrin loss of function mutation, which means that they're not producing any or very few, very small amount of natural moisturizing factor, deficiency in aquaporin channels, so that water is not being transported from one cell to the next and one level to the next, insufficient perspiration, and pH dysregulation, again, either coming from, excuse me, a disease process or from a genetic abnormality. Exogenous, we spoke about a moment ago, exposure to harsh chemicals and cleansers, patients with excessive compulsive hand washing, for example, very low humidity environments, heat, pollution, and exposure to allergens. And we're all very familiar with the clinical manifestation of xerosis, which is loss of hydration in the epidermis, so that we end up with flaking and scaling of the stratum corneum and dysregulation of the barrier function altogether. And then, of course, we can progress to more significant things like cracks and fissures and infections and severe pruritus and stinging and burning, as well as lichenification. So it can start off with simple xerosis, but can end up with something which is truly a disease process. So we're going to have a couple of polling questions as we go through today. And this is our first polling question. So which statement is true most often when recommending a body moisturizer to a patient? Please select one of the following. Is it a daily moisturizer is recommended to every patient who walks in the door? Visibly very dry skin noted during the examination so that you're called upon to mention it, or that the patient voiced concern about dry, itchy skin symptoms. So please go ahead and vote. And while you're doing it, I would say that I'm not a recommended to every patient kind of person. Oh, you guys are. That's interesting. So I tend not to mention it to every patient who walks in the door, frankly, because I think if they don't perceive their skin as being dry or having symptoms like itch, burn, and sting, they're unlikely to use it. So I think I kind of figure that maybe this is the time to save my voice and to spend my time talking about something else. But clearly, you guys, oops, it disappeared. You guys felt that you recommend moisturizers to every patient who comes in, and I think that's a wonderful idea. Hold on one second. I'm having a hard time advancing. Can you guys advance me to the next slide, please? I think we're stuck in a loop with the polling question. Maybe?
Try clicking in the middle of your screen and see what happens.
It's not working.
There you go.
There we go, finally. Okay. Okay, so let's talk a little bit more about natural moisturizing factors in terms of what's present in the Eucerin Advanced Repair cream and lotion. So for both the cream and lotion, it's formulated with natural moisturizing factors, as we said before, as well as ceramide NP, which we used to call ceramide 3, and cholesterol to strengthen the protective barrier. So in terms of natural moisturizing factor components, we have 5% urea, as well as lactic acid, amino acids, pyrrolidone carboxylic acid, and sodium chloride. Also ceramide NP and cholesterol, shea butter, sunflower seed oil, and all of this in a non-comedogenic, fragrance-free, paraben-free, dye-free product. So the cream is intended for patients with very, very dry, rough, flaky skin who want a very rich texture, but not greasy therapeutic moisturizer. And the lotion is for dry skin, but perhaps not quite as rich, and in a patient who perhaps likes something that's a little bit lighter. So the benefits of both of them are intensive hydration, as well as strengthening and repairing the skin's protective barrier, thanks to adding the natural moisturizing factor and adding back ceramides, which may be deficient in the xerotic skin. So let's take a little bit deeper dive into the components of both of these products. As we said before, we have ceramide NP. And ceramide, when the ceramide levels are reduced, we have a deficient skin barrier. Ceramides represent about 50% of the total by weight of the lipid barrier. And when the lipid barrier is not functioning well, as we said before, we've got a problem with transepidermal water loss. The benefits are strengthening of the skin barrier and helping to reform the protective lipid barrier and support barrier repair. We also have 5% urea in the cream, as we said before, and we know that urea levels are reduced in patients with xerosis, a 50% deficiency in patients with xerosis, and up to 70% deficiency in urea in atopic dry skin. We know that it's part of the natural moisturizing factor, so it's drawing in and holding on to water, hydrating the skin, and in higher concentrations, urea also has keratolytic properties. So the benefits are binding that water, helping to relieve dry, itchy skin, and perhaps also reducing scaling on the surface of the skin, thanks to the keratolytic activity of the urea. So let's take a look at a study that looks at whether all of these products, all of the components of this product are necessary. Because some of you might be thinking, wow, there's an awful lot of stuff in this product. How do we know what's working? Is everything necessary? Is it what's bringing the most to the table, for example? So this was a study that was intended to look at that. We have 36 healthy subjects, and this was a double-blinded, vehicle-controlled study where the following products were applied to the inner forearms of the test subjects. So there's one site that was untreated that served as the control, and then you had just the vehicle, which are the lipids, including ceramides. Then you had that plus urea and lactate, which they referred to as vehicle plus. And then product 3 is the entire product, the Eucerin Advanced Repair Lotion, which is the vehicle plus, and the addition of the natural moisturizing factors. And the patients were assessed for skin hydration with corneometry, as well as skin barrier function with transepidermal water loss. So let me ground you to the graph on the right. What we're looking at here is corneometry reading units. So the higher the number, the better the hydration of the skin. And we're looking at it at 3 time points: at baseline, 1 week after twice daily application, and 2 weeks after twice daily application. So the gray bar down at the bottom is the untreated control. A, or the dark blue line, is the vehicle alone, so that's the lipids, including the ceramides. And we can see an increase in hydration with the addition of the ceramides. The red line is vehicle plus, so it's ceramides and urea and lactate. And we see that hydration is increased again, thanks to the addition of these other products. And finally, the teal blue line at the top is the entire product line. And the difference between the red and the teal is the addition of natural moisturizing factors. So we can see that the ceramides helped, the urea and lactate helped, and the natural moisturizing factor ingredients helped as well. So each one of the ingredients in this product line is essential to the overall functioning of the product line and its quality hydration of the skin. So many of us over the years have been using CeraVe moisturizing cream. So we did a head-to-head study between Eucerin Advanced Repair Cream and CeraVe moisturizing cream. So in this study, 33 people with very dry lower legs were given in a double-blind fashion, bilateral application, one product on one leg, one product on the other leg, once a day for 10 days. Then the product was stopped. Both products were stopped. And 5 days later, they were evaluated for how well they were still doing, despite the fact that they had not been using product for the last 5 days. So they were assessed at baseline at day 10 and 5 days after discontinuation on day 15. And they were evaluated by corneometry looking at skin hydration. And this is what they saw. So here we're looking at the end of day 10. So now, and this is the point at which they've been using the products, one on the right leg, one on the left leg, in a randomized fashion, double blind, for 10 days. And Beiersdorf likes to call this filling the moisture reservoir. And I actually like this concept. We'll talk about it a little more in a moment. So we're looking at corneometry units, which means the higher the bar, the better, the more hydrated the skin. Eucerin is dark blue on the left, CeraVe is in the gray on the right. And you can see that both products had a significant improvement, mean change from baseline. And that's represented in the 2 stars, which shows statistically significant improvement in hydration from baseline. But then that double cross on the Eucerin side shows that the Eucerin was statistically significantly superior to the CeraVe. So both of them worked, but CeraVe was statistically significantly superior at filling up that moisture reservoir. So now we've stopped it for 5 days, and now we're looking at what the patient looks like 5 days after that. Right? So we can see, again, both Eucerin and CeraVe with statistically significant improvement compared to the baseline 15 days ago. Obviously, it's gone down a little bit. They haven't been using any moisturizer in the last 5 days, but Eucerin didn't go down nearly as much as the CeraVe did. It's a numerical difference. This is not statistically significant, but at the end of 5 days without the moisturizer, the skin that had been hydrated with Eucerin had a bigger depth of the moisture reservoir, so that it hasn't been used up yet, so to speak, than did the CeraVe side. So we've always said, or at least we've always believed, that when you have really super dry skin, you have to use a cream. That lotion is really only appropriate for people with mildly dry skin, and that a lotion could never be superior to a cream, all other things being equal. So now we have a head-to-head here between the Advanced Repair lotion of Eucerin to that very same CeraVe moisturizing cream that we just looked at a moment ago. So the same kind of study was done. We've got 35 patients with very dry legs. The Eucerin lotion is applied to one side, the CeraVe moisturizing cream applied to the other in a double-blind randomized fashion, once a day for 10 days, and then it's stopped, and it's reevaluated 5 days later. So the patients are assessed again at day 0, day 10, and day 15 by corneometry, which is looking at skin hydration. And you can see in the graph on the right that at the end of day 10, which again is called filling the moisture reservoir, Eucerin is statistically significantly better than is CeraVe at increasing hydration of the skin compared to baseline. Both of them showing an increase in hydration, but Eucerin statistically significantly superior to the CeraVe. And on day 5, the same thing we saw before, a numeric superiority of Eucerin over CeraVe after the patients have not been using their moisturizer for 5 days. Now, why regression phase? Why even look at that? Well, our patients, shocking, I'm sure, to all of us, our patients are not always compliant with what we tell them to do, which is to moisturize their skin every day. So it's nice to know that if they go away for the weekend and they don't bring it with them, or they are not terribly compliant, that thanks to having filled the moisture reservoir, it takes a long time for that reservoir to run out of moisturizing factors when you're using the Eucerin cream or the lotion. So in summary then of this portion, we've looked at Eucerin Advanced Repair Cream and Lotion compared to CeraVe Moisturizing Cream. So on the left, we see the cream versus the cream, and we saw statistically significant improvement in skin hydration after 10 days for Eucerin versus CeraVe, and sustained hydration with numeric superiority of the Eucerin over the CeraVe 5 days after discontinuation of the product. And on the right, we have the comparator of the lotion to, again, CeraVe moisturizing cream. And the lotion here is statistically superior to the CeraVe cream. So it's not true that you have to have a cream in order to do a better job at treating dry skin. If your patient prefers the feel of a lotion, the Advanced Repair Eucerin lotion provides adequate hydration of the skin and does so better than CeraVe moisturizing cream. So why might that be the case? Well, if we look at CeraVe moisturizing cream over on the right, it contains ceramides, as we well know. That's why it's CeraVe. But the Eucerin Advanced Repair formulations contain not only the ceramides, but also the natural moisturizing factors that we see over on the far left. So clearly, the addition of the natural moisturizing factors goes above and beyond the addition of ceramides to the product in terms of its ability to hydrate the skin and for that hydration to maintain even after 5 days of discontinuation. So now I'd like to propose a second polling question. So when recommending a product for patients with xerosis, what do you consider to be the most important aspect of that product? Is it your own personal preference? patient feedback, availability and affordability, proven clinical efficacy, as I just showed you, for hydration and barrier repair, or is it the formulation and the ingredients? I think I learned very early in my career not to not to rely on my own personal preference, because you never know what a patient enjoys putting on their skin until they do so. So you agree with me. Your own personal preference is not part of your, not a big part of your decision-making process. The availability and affordability, of course, very important, and proven clinical efficacy for hydration and barrier repair. So you guys as a whole are impressed by the data, as well as a product that the patient can actually afford and then actually use. I think patient feedback is very important, because if the patient isn't happy with what they've applied to their skin, they're not going to end up using it. But otherwise, I completely agree with you all. Oh dear, same thing happened this time. Okay, so polling question number 3 now. Based on the clinical data presented, do you think you're going to recommend use or an advanced repair formulation with natural moisturizing factors and ceramides more often, about the same as you do now, or less often? So please vote. I'm pretty impressed with this data, and I'm also very interested in learning more about natural moisturizing factor. I think it's a fascinating concept. We've been talking about ceramides for so long, and here we can see the reason and the rationale for adding natural moisturizing factors as well. So more often or at the same level you do now, but nobody apparently said less often. So I guess the data was compelling. Can you guys advance me to the next slide, please? Because this is just not flying. Ah, there we go. Thank you. So, Leon, I'm going to need your help on this one. Let me present the case to you and see what you think about it.
I am honored that you need my help.
So we have a teacher, a woman, who lives in Boston, and you know that brings with it all sorts of cold weather during the winter months. And as a teacher, she's probably washing her hands a whole bunch. And she's experiencing very dry skin on her hands, as you can see, but also on her arms and her legs. And she wants some advice on what she should be doing that's going to restore her healthy looking skin, as well as reduce, improving the health of her skin. And she tells you she doesn't have any problems with sensitive skin. So you know, nothing's ever bothered her in the past. Where would you go?
So, I would start with, first of all, make sure that she's not washing her hands with hot water, maybe lukewarm towards cool water. And then instead of drying them with a towel, sort of air dry them, and then apply the Eucerin Advanced Repair Cream. I would like the cream in this case rather than the lotion. I think it will stick better. And then sometimes even recommend a glove to put the gloves on the advanced repair cream, sort of to occlude it and even further to push it into the skin while it's nice and moist right after washing the hands.
Yeah. Do you ever prescribe the cream and the lotion and just sort of let them pick where they want to put what? Because personally, I like a cream on my hands, but
Right.
I'm not so fond of a cream if I'm getting dressed and going to work in something relatively expensive.
So my favorite for cream, my favorite places are the hands and feet.
Right.
And then the rest of the overall, the trunk especially, or the arms and legs, the lotion.
Yeah. And I like to give them both and let them pick and choose where they're going to apply it. And also time of year, right? I mean, if she's in Boston in the summer, lotion's probably good enough.
I mean, look, those are very reasonable prices. It's over the counter. You can buy it. And it's not a big deal. Why not to have it both and then try it and see what they like, what they want to do with it.
Well, thank you for helping me with my
My
patience.
pleasure.
Appreciate it. All right. So we're at the end. We're at the summary and key takeaways. So we've looked at Eucerin Advanced Repair products, the cream and the lotion, and we've seen that the advanced formulation goes beyond just ceramides to address the multiple causes of xerosis, which includes a deficiency of natural moisturizing factor. And the addition of these natural moisturizing factors to repair the hydration, along with the ceramide to help repair the lipid bilayer, Eucerin Advanced Repair Cream versus CeraVe Cream showed superiority of the Eucerin Advanced Cream. But perhaps more surprisingly, the Eucerin Advanced Repair Lotion showed superiority over the CeraVe Cream as well, additionally showing how important it is to have natural moisturizing factors as part of the components of your moisturizing system. So I think we are at the end of the slide deck. Oh, I'm sorry, polling question 4, I forgot. Polling question 4, what is the top influencer here? I hate that word. That would help convince you or try or to recommend Eucerin Advanced Repair more often? Is it additional published data showing clinical efficacy? Do you want to have a conversation with your sales rep? How about samples and coupons for your patients? Would you like a sample personal trial, a larger container to take home and have everybody try? Or I would not recommend Eucerin Advanced Repair more often. So why don't you go ahead and vote on that as well, so that Beiersdorf can better understand what tack to take in making you and your patients happy. All of the above, except I would not recommend it more often. So let's see here. Published data, a little bit more published data, samples and coupons. So this sort of goes hand in hand with what you said before, doesn't it? It's affordability and the data that's impressing you. But you would also like some personal samples so that you can give it a try for yourself and take it home to your family. Okay, so can we go to the last slide, please, which I think is just saying, thank you. Do you have any questions?
So thank you so much, Hilary. That was very eye-opening. I learned a lot. We have a bunch of questions from the audience, and
Yeah.
I'm gonna start from my favorite downstate classmate, my medical school classmate from Dr. Diane Kubel. She is in Boston, and she's saying she just ordered 3 lotions and 3 Eucerin Advanced Repair Cream for my aesthetic practice. So thank you, Diane. And her next question is, how about milk soaks for the teacher's hands?
What soaks?
Milk soaks. Milk.
Oh,
Yeah.
oh, yeah. Wow, that's old time. It's one of my favorite recommendations to people with dry, itchy skin on any place on their skin. Any place on their body. I like to fill a bowl with whole milk. It has to be whole milk. It can't be skim. It has to have lots and lots of grease in it, and ice cubes. And then take a nice soft cloth, like a real old pillowcase or something, and dip it in, wring it out, and apply it to the skin. It helps so much to relieve itch, both the grease of the milk as well as the coldness. And it helps poison ivy. It helps atopics to be able to go back to sleep. And then you moisturize on top of that. Completely in agreement. Although the patients do look at you a little oddly when you recommend that they go and buy whole milk on their way.
But you know, I tell them, isn't that what Cleopatra did for her
Yes,
skin?
that's right.
So
It's good enough for Cleopatra.
all is new. Next question is, so after seeing this data, what's the key advantage of recommending Eucerin Advanced Repair as a daily moisturizer to the patients?
Well, I'm really buying into this natural moisturizing factor concept. I think it's crucial. You know, our patients with xerosis have deficiency in natural moisturizing factor. They also have deficiency in ceramides. So in order to really repair their barrier, you need to have both so that you're hydrating the skin and then sealing in that hydration by improving the lipid bilayer as well. So I think the data speaks for itself.
Also, going back to that regression study head-to-head with CeraVe, Is that significant for your patients, and why is that? Especially given the fact that those are two over-the-counter products, right?
Right. Well, as I said before, our patients are not terribly compliant. Especially if they have terribly xerotic skin or they have atopic dermatitis or psoriasis, we're recommending to them that they moisturize every single day. That's highly unlikely. I can't get myself to do it. And patients are not likely to be moisturizing on a daily basis. And if they're going away, if they have a large trade size, they're not going to check their bag just so that they can take their lotion with them for a weekend. So it's nice to know that if they fill the reservoir, that's why I like that concept of filling the reservoir and the depth of the reservoir. If they filled their reservoir and then they don't bring their cream with them, yes, their hydration is going to go down, but nowhere near the way it was at baseline. So it's a
Yeah.
safety net for the non-compliant patient.
So again, my good friend Diane Kubel, she's thanking us for presenting the real-world study and not only using a placebo vehicle. And that's really true when you look at those moisturizer studies, right? So what do you use? What's the vehicle? And I love the fact that they use nothing, then the vehicle plus the urea, and then finally the product with the natural moisturizing factors. Makes it so logical, seems so scientific.
Yes, and you recognize that each one of those ingredients was necessary
Right.
to accomplish the goal that they accomplished, which is incredible hydration very, very rapidly. So, yeah, I'm very fond of that study as well. I think it's very
Now,
helpful.
there's an interesting question, and honestly, I don't know the answer. Maybe you do. Can this product be used by someone who's allergic to sunflower seeds?
As I understand it, the sunflower oil has been very highly refined, and refining the oil removes the protein, which is the part of the molecule, part of the product which is allergenic. So my understanding is the allergenic components have been removed and you needn't worry. But if you have an aggressive, probably the wrong word, if you have a significant allergy, probably best to move on. But it's not been a problem over the years with Beiersdorf products with the addition of this very, very helpful oil.
That's interesting. It's good to know. Another question is, when looking at urea for moisturizers for hands, would 10% be okay, or is this too much?
Yeah, 10% is going a little bit over the top. We're getting towards exfoliation here, and it would probably sting. So it's 10% and above of urea that really is a keratolytic. So you probably want to stay with the 5% that's found in this product in order to hydrate the skin without doing too much in the way of exfoliation.
Yeah, I like 10% and more for the heels, right?
Yes, me too.
Another question is, for what patient type is the Eucerin Advanced Repair formulation is relevant, and why?
Can we reverse the question and say, in what patient would it not be appropriate? Because
I
honestly,
love that. Why not? Yeah.
if you have dry skin, why wouldn't you use the product that repairs your dry skin the best? So, can't think of any patient who would not be a candidate, to be honest with you.
Yeah, I totally agree. Why not? Well, perfect. I think we ran over all the questions, and I thank you so much for this great program, for the great lecture. And people don't think about it, but the moisturizers now have become quite scientific, and to understand the stratum corneum, that it's actually a dynamic barrier. It's not like the pile of dead corneocytes, right? So we're learning more and more, and that's fascinating. So I'd like to thank you very much, Hilary, joining us tonight, and I'd like to thank our supporter, Beiersdorf, makers of Eucerin and Aquaphor. And since we are done with the Beiersdorf program tonight, I'd like to remind you our next program on May the 30th, Thursday, we're gonna have Dr. Jennifer Saar on the latest approved indication for cosmetics. I thank you so much, everyone, and have a good evening.
Bye, Leanne.
Bye.
Have a good night.